Hello, and welcome to this education program. This is called From the Frontline, communicating with your patients with Alzheimer's disease or some other dementia. Thank you for being with us. This program is primarily for healthcare providers. It was developed with support from the Donald W. Reynolds Department of Geriatric Medicine at the University of Oklahoma Health Sciences Center, where we are right now, and also with strong support from the Health Resources and Services Administration, an agency of the U.S. government. Thank you very much for them. An important key to effective care of individuals with dementia is achieving successful communication. That's really important. It's not always easy, it's not always predictable, but we hope that today's program leaves you a little better prepared to have success with your communication with your residents and your patients who have dementias, and we hope that this will be of value to you. The way that the morning will work is first we'll speak with a neurologist and a geriatrician. Then we're going to hear from some frontline providers who work in residential settings with individuals who have dementia, and then we'll wrap up at the end. We think this will be a little under an hour, and we hope you stick with us. Thank you. So let's move now to an interview with a neurologist. Dr. Odenheimer is an associate professor with the Donald W. Reynolds Department of Geriatric Medicine here at the University of Oklahoma Health Sciences Center. She is a neurologist with specialized training in geriatric medicine. And of course, she has specialized expertise in cognitive impairment. So she is very well positioned to give us some insight on not only the background of Alzheimer's disease and other dementias, but also the practical aspects of how to have successful communication and how to think about interactions with individuals. So let's go to those. Thank you for being with us, Dr. Odenheimer. We have a couple of questions, but we're going to just let you speak from your heart and your mind about these things. Let me just toss one out and we'll get the discussion going. Could you please speak with us a little bit about how to help or hinder communication with individuals who have Alzheimer's disease or other dementias?
Yes. I think that some of the core things are the approach to the person and treating them as if they are still human beings. I think that you need to address them from the front. You don't need to surprise them. You need to not give them too much information at once. Allow them to take in what information you've given them and then move on. I think one of the big issues in facilities is that they're rushed. They're trying to get a lot done, and that carries over to their attempts to communicate efficiently and quickly, and in fact what ends up happening is that the patient or the resident becomes more agitated and more resistive to care, and so what they think is being efficient turns out to be inefficient.
Right, that's very helpful. You are describing some mechanisms or some approaches that would address possible confusion in an individual who might not recognize who you are or what your intentions are. Does that sound right?
Sure. In fact, I mean, for the staff, that's particularly important, but even family, at some point, the person may not recognize them anymore. So what the person will usually continue to key in on, though, is how you connect with them. And so you can introduce yourself every time you see them because they may not remember. But beyond that, you have to realize that they're picking up on your emotions and your eye contact and your gentleness and your respect. And those are the things that allow you to communicate more effectively. So whether they know you or not, they may know that they like you or don't like you, and those will make a difference.
The individual who has the impairment may not know the name of who is coming in to help or change the linens or bring food, but often facial features and recognition that this is a person who has been around may still be present. So is that?
Yeah, absolutely. And that's one of the reasons why, you know, when families maybe think about moving a person from facility to facility or from one room to another, or actually moving from lower level of care to higher level of care, some of the problems that come with that is that even though the person may not be able to articulate that they know where they are and who the people are around them, when you move them, it becomes clear that they're very disoriented, and this is very disruptive to them.
In your experience, are residential settings well prepared for this? In the individuals, the professionals who work in those settings?
Yeah, it's highly variable. And I'll give you an example. My whole career has been around dementia-related issues, but I really learned a lot more about it when my mother began to show signs of dementia. She's now in an assisted living facility, and they like to give showers, and she would be very resistant, and so then they would insist on giving her medication to, quote, calm her down so they could give her a shower. However, she really preferred baths, and she really preferred baths before she went to bed, not in the middle of the day when she was scheduled. And also, I think the staff, because they were rushed and did not appreciate that she still was connecting at some level, were not connecting with her, because there were staff who did not need to give her medication to give her a bath. So it was clear that the medication was not the issue, it was the approach that was the issue. And now we've stopped those medications, and they have stopped saying that she's agitated. So they have apparently adjusted their approaches to her and met the things that are important to her, like a bath in the evening, things like that.
Is there an approach that that allows the providers to put themselves in the shoes of the older individual and begin to ask for compliance or ask for participation in a way that reduces agitation?
One of the things is that there is a movement in this, fortunately, in this country that's trying to shape the environment to what's important to the patient. I would say we have a long way to go with that, but things like, when do they have to get up? When do they have to toilet? I mean, of course, if we work, we have to get up. But if you don't have to work, you don't have to get up unless you live in one of these places. You know, when you toilet is a pretty private thing, but people will have schedules, and so those kind of things can be very upsetting if they're very different from the person's original setting. I think the other thing is that staff will sometimes approach the patient or resident very tentatively, and they'll say, would you like to take your medicine now? Would you like to take your bath now? And usually they'll say no. But if you say, it's time for your bath, let's go, then they usually will say yes. And so, there was a time when my mother was not getting bathed at all, because they would always ask her, would you like to have your shower or your bath now? And she would always say no. So I'm going, so she's not getting bathed? And she wasn't. So we had to work on that issue.
And so in your experience, by recognizing where there may be a different approach staff could take, it didn't necessarily increase their workload or increase the amount of time that they may have spent?
In fact, it probably reduced time. It certainly reduced stress. And it made their job more fun, because now these were people to them and not just charges. And I think that when the staff get to know the residents and learn more about them and their families and stuff, that they can develop a bond that I think greatly enhances their ability to care for them.
If someone says, I'd like to go home, what's your answer?
Right. That's a great question, because that is so common in people who are living in these facilities. I mean, when I walk through these facilities, I hear it all the time from people. All the patients are saying, I want to go home. And with my mother, that was a common thing. And she lived in New Orleans until the Hurricane Katrina laid waste to the city. She moved out with an overnight bag, never went back. And as her dementia progressed, she would continue to say, I want to go home. And because I'm a big believer in telling the truth, I would tell her the truth, you know, that your home was damaged, that we sold it, that, you know, she'd want to know where her car was, we donated it to a charity. Those things became so fraught with anxiety and anger, so that, I didn't give you authorization to do that. I want it back. I want to go back to my home. Where's the money? So at some point, and actually it was my daughter who wisely pointed this out, because she knows how I feel about truth-telling. She said, "Mom, who is that truth for? Is that for you, or is that for your mother?" And that, I thought, was a very pivotal moment in me saying, sometimes there are ways to tell the truth or a variation of the truth that is less painful to the person. So for example, now when she says, I want to go home, I say, "Where's home, Mom?" And it's often a place she was as a child, or, it changes all the time. So then I just I ask her, "Tell me about that. What was that like?" And as she starts talking about this, the issue of wanting to go home becomes less intense. It'll come back, but now I've found a way that we can talk about it without it becoming such a devastating discussion every time.
Right, and so I guess what I hear you saying is that truth-telling and redirection have similar paths, and to use them effectively doesn't demean the relationship that you have with an older person.
Right, and I think
impairment.
I think I was stuck with honoring my mother's intelligence and my relationship with her. I was stuck in the truth-telling mode, which in the long run was hurtful. There's a wonderful story I heard at a meeting that is the best story of redirection I've ever heard. It was the man who had Alzheimer's disease was holding a knife, and he said to his wife, "I have to kill you now." And she, without batting an eye apparently, she said, "Would you like ice cream first?" And she went to the freezer, set out ice cream in bowls, and got the spoons out. Pretty soon he was sitting down with her having ice cream. He put the knife down, which she of course confiscated, and kept knives out of his hands afterwards. But it was a beautiful example of redirection.
Right. Using a communication or a message that fits the capacity of the person with some cognitive impairment, the capacity of the capacity that they have to understand what you're asking, and to not confuse the issue with a lot of details. I hear you
Right.
say may be valuable.
Right.
Okay, and possibly comforting. So
Right.
that's a goal that we all have.
And I think what I try to tap into with my mother is joy, and she still has that. There are times when she's not very joyful, but there are ways that we're able to find joy and find humor. I'll just give you a quick example. I was taking her back from a doctor's visit, and I was putting her transport chair in the back seat, and I accidentally hit her in the head with the handle. And I went, "Oh, Mom, I'm sorry. Did I hit you in the head?" And she goes, "Yes." And I said, "Did I hurt you?" And she goes, "No. Would you like to try again?" And we both laughed at that. So
The moments of insightfulness are wonderful. So these are not medication answers. These are not solutions that are classic neurologic approaches necessarily. Is this new? Are we re-establishing something that has always been the case? How do you think this notion of putting ourselves in the shoes of the older individual and getting a sense of what their reality is, and then operating within their reality, where is that on the landscape of medical care for older individuals with cognitive impairment?
I think that we're moving in that direction, and probably there was a time in our past when we had extended families and people were more accepting of different kinds of disabilities. Everybody just pitched in. Now it's a very different society. So I think in the process of this society dissipating and becoming technologically oriented and becoming regimented and policy driven, that we've lost touch with some of that humanity, and now I think we're trying to recapture it. And I think that those people who manage to do it will find joy in their work, and the people who can't do that are not going to be happy with what they're doing.
So there's a job satisfaction issue as well.
Absolutely.
And we all know the trouble with turnover and burnout, because it is a challenging career to serve other people, particularly those who have increasing cognitive impairment.
Right.
So should we hear from some of those folks?
I think that would be great.
Now we have an opportunity to hear from the Frontline, providers who work in long-term care residential settings, and some caregivers who now visit their loved one who resides in long-term care settings. This is a question-answer session with a handful of individuals. It runs about 20 minutes or so. We hope you stick your way through it. It's very insightful. These are heartwarming individuals who know how to do this work correctly, and I think that you'll gain some tips that will work for you in your own setting.
This disease has taken away a lot of their personality, that I will never really know them like their family knew them. And so I have to look beyond that, and I have to listen to the family. I have to listen to what they've told me about this person, who they are, who they were before this disease began changing their personality. I always say it takes, as far as when a new resident comes in and for them to get acclimated to the environment, it can take anywhere from 2 to 4 weeks, but then again it can be just on a case-by-case basis. It can depend on where they are at in the dementia stage. You never really know, and some people you might think, oh, they're going to have a hard time adjusting, and you come back the next day and they're already acclimating, they're socializing, and those are the happy, you're just like, yes, this is going to be a success.
For our morning activity, music and movement, I have the chairs in a circle. We start with songs with a guitar, very cheerful good morning type of songs, and things that they remember, that they would know from growing up. Have lively discussions. We throw big beach balls around. We have games that they enjoy, beanbag and horseshoes. But all this is in a circle so that they see what's going on. Some of them can participate, some of them can only watch. Some of them are not moving, but the ball is placed on their lap, and then we help them roll it. So you just make adaptations for what they can do.
No matter how somebody has told them that they were sick and you were placed here because of your sickness, I don't want them to wake up thinking I'm sick. I want you to wake up that you're a human being and I love you just the way you are.
Our communication efforts change based on the different stages as far as what they are able to still be able to retain just for that moment. We have some that are very late stage, and they may not be able to communicate as far as we normally look, make eye contact, we smile, we use a tone that may be a little more sing-songy, so it's not as a demanding voice, but it's more of a calming, reassuring voice. And we continue that voice, but as dementia increases, they lose the ability to speak. They lose the ability to swallow and start having swallowing impairments and things like that. And so we communicate with them with the same respect and dignity, looking at them, but we may have to use more touch. We try to incorporate that anyway, but more touch. I always make sure that staff is aware of the fact that they need to make sure when they're feeding a resident or anything that they're doing, that they're constantly telling them what they are doing prior to doing it. So it's not a scary, someone begins changing a resident and it's not scary and violating. This is what we're going to do. You're safe, you're okay, and now we're going to do this so you'll be clean and dry. And it's just always a reassuring and dignified way of dealing with them. Even to the end, you're able to communicate when someone is dying. And this is the same with a dementia resident, is communication, the power of touch, never underestimate that. They can feel and they have emotions, and they may not know and be able to cognitively reason why they're feeling a certain emotion, but if they feel loved because you touch them and that reminds them, it brings back that comfort of being held by their mother as a child when they were injured or something like that, then you know that you've affected them positively in that day. You've comforted them and given them just kind of a little bit of a reminiscent moment. Body language is by far more important than the words we actually speak. The tone that we use and our body language is so important, and so it's the same with dementia residents. We have to make sure that we are, addressing them, and our body language is conveying the message that we're saying. But honestly, the best thing is going to be that applying it, is that hands-on care of learning that some things are going to work some of the times, nothing is ever going to work every time. My advice for anybody coming in is to, when you work with them, is to look beyond the disease. Do research. We do social histories. Find out as much as you can about them, who they were before, because automatically then you have a respect and an understanding for who they are as an individual. But then you also have, during times that you need to redirect or times of reminiscing, that you have something to pull from. You have things that are special and pertinent to them and their lives, and those are all comforting things for them. And then you can actually experience a bit of their past, and they kind of bring you into their world for a little bit, and that's pretty rewarding.
Well, Alzheimer's is such a terrible brain disease, and it affects people in different ways at different stages. And they lose the ability for judgment and reasoning, but they don't lose the ability to feel things. And for a person to feel bad or feel sad, you can turn that around very easily by just some meaningful conversation or interaction with that person. It doesn't always work, but most of the times it does. I feel like there's the spark of life in each person. Some folks, you hardly see it at all, but when you sing a special song in their ear with them, and you see the light come on with Jesus Loves Me, or something that they knew when they were a child, that's, I see that every day as far as when they relate to something, or they just they relate to joy, they relate to genuine feeling. I don't think it helps to treat them like children, because they're not. They're adults. When we have a church service, which we do every week, I can tell that they respond. They enjoy being talked to as adults. They're hearing sermons that very much like they grew up with. It's not baby talk. It's not, now you got to go to the bathroom. It's not these day-to-day drudgeries. But when they're spoken to like adults, and simply bringing in things that are joyful that they could relate to, then they respond very favorably. I notice in communicating, we all have different ways, and we try whatever works to communicate. And some little keys that I try to do is to not use the word remember, because for some reason we think that we are just not communicating if we don't remember our grandchildren, or remember that we went to Europe, or remember this, remember that, or remember Elvis Presley. Instead, I've tried really hard to cut that word out and just say, or just begin talking about the discussion, and they nod their head and they agree. The moment we say, remember you're supposed to do this, there's a look of, oh no, I did something wrong, because they don't remember. And so that's a key word that I would like to see caregivers try really hard not to stress, and yet it comes to our mouth just naturally, because that's how we talk about things.
Well, they just need to be very patient and very caring, and if they feel so inclined, they need to be loving toward them, because they're kind of in a situation where they could get unhappy pretty quickly if somebody wasn't nice to them, or yelled at them, or told them, no, you can't do that, There are nicer ways to do that, to control. I'll just give you an example. When I've been in the memory care unit seeing Emily and I'm ready to leave, many times she's reluctant to let me go without taking her with me. But if a staff member, a nurse, or an aide comes and puts their arms around her and hugs her and says, no, Emily, you need to stay here, she's okay. she stays.
I hope when I say this it makes sense as far as a breakthrough moment, but when I first came on a memory care unit, and I think to most who are coming through or just visiting, it seems a little odd. It's not the norm as we typically think is normal. And you go through and there are people asking questions and, asking questions over and over again, and there may be some behaviors that don't seem typical for adults to be doing. And then one day, that becomes your normal, and you understand how to communicate in their world. And their world is just as perfect and beautiful as the outside world. It's just different. And so I think that's the moment that one day I just came in and this was my normal and this was my home, and I felt like, it was okay, that these behaviors were different, but they were still okay.
Well, you definitely learn about living for the moment, because there's no past and there's really no future. It's just about right now. When we have a program that maybe there was a lot put into it and people say, well, why are you doing that? The next minute when you walk out the door, they won't remember that you did it. It doesn't matter, because it's that moment that they were experiencing joy, affirmation, just the good feelings that we all deserve to have. And if that stopped the minute you went out the door, then that doesn't mean there's been failure. You've succeeded for that moment. So I've learned, that not to worry about my past and not to worry a whole lot about the future, but live the moment.
It is different, because some of the words, they don't understand the words, so it's more role-playing those out. But it's not that they can't, understand, like for brushing their teeth. We have to assist them with that. But just being able to pull, just to put their arm to their teeth and then just show them the motions. It's, it may not be verbal communication, but you're still communicating with them. Like you said, the body language is very important.
I think more about their feelings is when I care about you, no matter if you're sick, you're up, it doesn't matter. It's just, that you approach them with that love and care. It's the way you touch, the way you speak, and they understand that. Your eyes and your hands, it says a lot in the morning. It says a lot for you anytime you speak to them.
Well, it's so important because if she's busy, she's happy. She's been a happy person all of her life, which makes me a lucky guy. But if she's not busy, she gets bored very quickly. And then she's not quite as happy. So they keep her busy. Of course, I don't know that much about her when I'm not with her, except that I'm told she's usually very happy and she's more than willing to help the staff with whatever they're doing. In fact, you can hardly keep her away from it because she's so used to being helpful. But when I'm with her, she just is totally concentrating on me and me on her. And we enjoy those times together.
One of the most important things is we never tell a resident that when they say, I want to go home, we never say, you are home. Because to them, this isn't home, and it will never be home. The last place they lived may not be home either. It's probably going to be somewhere that they grew up with their mother and father and their siblings. And so where we always remind them is that they're right where they need to be, that they're safe, and that we're going to do everything we can to take care of them and to meet their needs. And so that's what we always try to reassure them, that they are safe and they're doing what they need to be doing and they're where they need to be. When we're working with Alzheimer's patients, redirection is something that's done pretty much continually. in earlier middle stage to later stages in dementia, you actually see some of the behaviors that may be a little more volatile at times because that's just the stage that we see it. And so those behaviors may be wandering, pacing, intrusive behavior. You know, they shut a door, what's behind there? They shut it, what's behind there? And so it's a continuous. But with redirection, you can redirect them and kind of get them on a path that they need to be on. And, you know, later then we have the redirection. It can be from the pacing, the wandering, to possible, you know, behavior that's not safe for them. And we do a lot of that, but it is something that you do continuously.
It could help with even redirecting. If for instance, you know, you're assisting with bathing, or you're assisting, you know, with getting them dressed, and they may you can bring up those things in their past, and even if it just triggers it for a moment, you develop that trust with them, and that's what it is. They're scared. You know, they're in a world that's different than, you know, than and some still have that cognition to be able to know that it's different, but they just don't quite know how different it is. And so you can bring that up. You know, you can help incorporate that into their everyday care task. And just knowing the person, I mean, just knowing people, you know, just being able to know. We have a gentleman that does, you can tell, I mean, he starts like walking in place. He's trying to walk forward, but he just can't remember to just do that. So you kind of stop him, and you look in his eyes, and you look directly at him, and you can just hold his arm, and then we just say, okay, let's take one step, and then that stutter is gone. You know, then he'll get back into his pattern. So being able to notice that, it's going to, you know, help prevent falls. You know, and it just gets him back on his path, and he's, you know, it's just knowing those little things that you can see to try to be proactive. I had just here a couple of weeks ago, there was one of a resident that a couple of caregivers had tried to give medications to her, and it's her important medications, the one that you keep your levels at a particular level. It's very important that she takes these. And I was walking through the unit, and they were letting me know, and I was like, well, just let me try. I'll go in there and I'll try. And she was very resistant. There was no way. She was sitting on her bed, and it was, so I, knocked on her door. I saw her sitting there, and I knocked and asked if I could come in. And she just kind of looked at me, and I thought, okay, let me kind of approach, go in a little bit. And so I, called her by name, and she said, I'm not taking that pill. I'm not going to take it. And I was like, I didn't come in to give you a pill, right now. And I said, but there's some trash over here on your floor. I said, do you mind if I pick up? There was just a couple of little specks. And she said, okay. So I picked that up, and I said, I'm going to go in your bathroom and just kind of clean off your counter if that's okay. And she allowed me to do that. And I said, do you mind if I sit down? So I sat down in a chair next to her. And she still was not really out, really sure that she really wanted me in her room. And so we started visiting, and I started talking about her family. And she had a couple of items. She had a baby doll on the side of her bed, and we talked about that. And I, said I would really like to have some ice cream. Would you like some ice cream? And I said, it's hot in here. So anyway, so I went and got us both some ice cream. And I started eating mine, and she took a couple of bites of hers. And I told her that I said, the doctor really wants you to take this medication, and I can put it in your ice cream, and that's fine. And she took both of her pills. She took them one at a time. The first one she took, and she was able to, do fine. The second one, she spit it out and told me that it was a seed. And so it was just being able to go back and, and I continued, eating my ice cream, but she took both of them. We have a gentleman that was in the oil field business years and years and years ago. And there was some behaviors that were needing to be redirected. And and he's moderate stage of his dementia. So my redirection for him at that time was to take him out to the courtyard, and we sat down and we just started talking. And I knew from his bio board that he was in the oil field. And so I started talking, and he actually knew some people that I actually knew years and years ago in the oil field, and he said yes. And then when his son came, because we were sending him out to see the doctor, I asked him about those, and he said yes. I mean, all these folks that I would mention to his father, it was amazing. And, he started tearing up, too, when we were talking about that. He can't remember the short term, but he still had that long-term memory of his passion that he had, as a work when he was in the oil field business. So it was delightful, actually, to see it. Being able to get him, number one, outside, remove him from a situation that was not going in the right direction, and then just knowing what he did, and I was able to connect with him at that time.
Reasoning doesn't always work, and so you can redirect sometimes. However, there are those that they know that they're being redirected and they resent it, and so it needs to be genuine. It needs to be not just, oh, let's talk about the blue sky. There has to be something related to that. If they're concerned about their family, then you can be reassuring that everything's fine. If I've heard some folks make up elaborate stories that say, well, it's too elaborate as far as explaining something, and that too many details are not needed. Again, I see that people function on a feeling level, and if you can use a few words that calm them, make them feel like everyone's fine. If they're worried about their mother, who's long dead, but yet they're very worried about them, then you need to say, she's fine, we'll be seeing her later, or I'm sure we'll see her later. You don't promise those things, but you make them feel like it's incredible how they can respond to just a simple that person's fine, and rather than a long elaborate story. But and I do see the advantage of entering into what they're thinking about, such as milking the cows, or they've got to get home and take care of the babies. And so you can talk about that like you agree with them, but you can also be reassuring and putting things off to a little bit later because someone else is taking care of it, and they visibly relax. At least the ones that I've tried to do that.
Don't ever embarrass them about a situation. If they have an accident, just act like it didn't even happen. You just take them and just go, all right, we're going to go and get beautiful again. We start all over again. You get them redressed, and they want to straighten themselves just like we do every day. They want to straighten themselves. Is my hair looking nice? And I always tell them that they're beautiful. No matter how they feel and what hurts them, I always let them know that you're beautiful. You're beautiful. And I keep stressing that to them because they want to be what they used to be. If you don't approach them right or say something to them in the right manner, you're not the boss of me, and I don't never want them to think that I'm trying to be the boss of them. I always let them try to act like they're my lead. I've been watching you all day, and you just look like you're just in such a good mood. Is there any way you can help me? It takes their mind off of things of trying to wander off. So if I let them be the lead, then they're taking me with them. I want to go. I want to be a part of this, or can I sit and eat with you, and that way I can assist in feeding at the same time. And always ask them would they like anything else, just like they would be at the restaurant, even when they're sitting. You always want to give them that right. Anyone else need anything? Do you need me? Can I help you with something? And they like that, Just reapproach them again when they don't want to do it right then and there. Just walk away and say, I'll be back to check on you. And a lot of time it just turns at the twink of an eye. So I like that they have that right to say no too, just like I would have that right to say no.
Families play a huge role in the care of of our residents. They're able to, number one, they know them better than anyone. So being able to visit with them and during the care plan meetings and things, and we can discuss at that care plan meeting. We can discuss the things that have changed, or with medication changes. It's just on a daily basis, and sometimes just being able to call the family and letting them talk, on the phone to their family member. It's very helpful.
I see her several times a week. Every Friday, I take her to social hour here, and our daughter comes and we have dinner together on Friday evening, and then on Sundays I take Emily to either our son's or daughter's house for lunch. I usually go to the church service here with her on Sunday afternoon, and spend some time taking our little dog over to see her, and she sometimes goes for walks with us. I can't imagine just putting her there and not ever seeing her, you know. We're going to have our 60th wedding anniversary day after tomorrow. And I'm not sure what we're going to do. We're, you know, kind of limited in what we can do. But 60 years, well, of course, I help in physical ways, that is to say, by providing whatever she needs in the way of clothing and all that stuff. But just my loving support, you know, when I'm with her, we usually walk down the hall holding hands, and we always kiss briefly when I first get there and when I leave, and sometimes we sit on the couch during social hour and hold hands, or I put my arm around her, whatever. We're still very close. Well, love is the glue. You know, I couldn't love anyone more than I love Emily. She's been the rock of our family in the past, and held the family together. Before I was a radiologist, I was family practice and did obstetrics and surgery. And if I was home for dinner, which wasn't real often, the rule was everybody stayed at the table till we were all through eating, so I'd have a chance to visit with the children. My kids later called that "watch Daddy eat."
What a wonderful comment from the good and retired Dr. Gardner. Compassion and caring are really essential tools for managing this partnership throughout life, even when one of the partners has a sufficient need to reside with greater care in a residential setting. So we can see how good care of individuals who reside in such locations can be done. We've seen it from a spouse. We've seen it from caring professionals at all levels of responsibility. And some of the things in specific that we've heard relate to the idea of paying close attention to the reality that individuals who have cognitive impairment have. What is their reality? Instead of trying to draw them always into our reality, recognizing that they have a reality that minimizes their own anxiety and their own confusion may be a really wise and successful way to communicate. So we also heard that professionals who work in residential settings or even in home care or other settings who interact with older folks with cognitive impairment, it's really important to take an assessment, take a mental assessment of what's happening in the room and what's happening with that older individual so that you can react appropriately. Determine if the approach that you're making is correct. Are you within earshot? Are you within eyesight? Does the individual know that you're coming and who you are and what your intentions are? Or might those be a surprise? So we want to avoid things that cause anxiety and cause confusion. And we heard that sometimes redirection is an appropriate and useful way of paying attention to truth-telling, but also getting to a comfort zone that makes great sense. Body language is important, that I just mentioned. We also want to interact. We heard that it's very useful to interact with older individuals with some cognitive impairment in ways that encourage them to do their own daily activities, to interact with the setting that they're living in. So we might say, why don't we go have dinner together, rather than walking in and saying, it's time for dinner, you need to be there now. So maybe a trite example, but a reflection of things that we heard from frontline providers doing it well. Thank you for joining us. We appreciate you taking the time to hear this. I hope that these have been useful. You can find other useful videos like this, webinars, at the Oklahoma Geriatric Education Center. Just type that into the internet and we'll pop up. And let us know if there are any other topics that might be of use for you to hear. Thank you for joining us. Goodbye.